I have a question.
Sure.
Uh, how do you find that patients that are currently going through litigation in dealing with their pain, do they tend to be more of the non-responders, or do they also respond well to CFT?
Yeah, it's a great question. We actually haven't done any specific clinical studies in people seeking litigation, but we've actually got a funding grant under review at the moment where we hope to. Look, we know that litigation is a massive issue. As soon as you start compensating people for their levels of pain, distress, and disability, it becomes a very powerful driver to reinforce it. And so once you've engaged with lawyers who are sending you to doctors who are reinforcing that you're damaged and that the more damage you have, the more money you have, the more disabled you are, the more distressed you are, the more you're going to get compensation. It runs in complete contradiction to the whole approach. It's a massive problem. And so I'm incredibly honest. I have a great case I'm seeing at the moment of a lady who, you know, presented to me after she'd had her back fused, who was seeking compensation. And she was going really well, terrified of movement, got her back moving in the gym, got her back, going to work. Then she was told to get her lawyer involved. And then she got a report from a specialist saying that, she was 20% disabled and she shouldn't be doing her work and she needed to protect her back. And she came in to see me completely distressed because she's going, I don't know what to do. I'm now stuck in this situation where part of me wants to go back into work and to do the things you told me. And the other part, I've been told that it's dangerous and that actually it's going to threaten my ability to get compensation for my pain. And I said, this is your call, but I promise you this, I don't see happy people who go through that journey. I don't see people lose everything in that journey. The money, your health cannot be calculated on money. If you go through that journey, you probably won't end up ever going back to that work again because no one will touch you. I don't think people are honest with these people. I'm very honest. I say, just be aware of what you're engaging with if you go down that path. I personally was involved in a motor vehicle accident a number of years ago where I was side impacted by a car that came through a red light, and I had pretty severe whiplash. And I made it a conscious decision not to engage with the motor vehicle accident insurance. So I was called by the person, said, look, you need to make a claim and go and see a doctor. I said, I'm not doing it. I'm not going there because I know what that process is like. It's toxic.
Mm-hmm.
It's toxic. It's detrimental for people's health. People don't get well in that system. They stay sick in that system. And ironically, most often when they get out of it, they don't keep seeking care. I think they're burnt by the system. So it's a huge issue. When we start compensating people for pain and disability, we often reinforce it. And these models are contradictory to good care, basically.
Yeah.
So great question.
Anybody else?
Also, when you have patients that have not necessarily back pain, but like osteoarthritis or something like that, where they have visible inflammation, how do you work them through the visible structure and get them past that to do more functional stuff?
Yeah, so I don't see knee arthritis as any different to degenerative disc disease in the back. If you think of Jamie's MRI scan, he had a degenerative disc, some motor changes. He's got a sensitive spine, but those factors are influenced. We know that, your pain experience for knee arthritis is influenced by your sleep, your mood. The risk factors for for pain and disability with knee arthritis is not what you see in your film. It's things like obesity, your mood, lifestyle, your levels of physical activity, your strength, your mobility, your confidence. They are the things that we need to target. So we would look at someone like that, just like with Jamie, and say, look, your knee's not perfect, but the way you use your knee is terrible. The way you're thinking of the knee is toxic. You need to engage with that body part, learn to use it, build the trust back in and make it healthy, because actually resting those joints, it makes them unhealthy. So I think we have a lot of fear around the body when we see someone I've got a great case in again of a chap who'd developed knee pain. He's around 65. He used to be he was playing a lot of hockey. He developed knee pain. He saw his GP. He ended up I saw a physio, got some taping or something crappy treatment. Saw his GP, got sent for an X-ray, showed arthritis. Saw a surgeon, got an injection in his knee, got 2 injections, had an arthroscopy, end up being in all kinds of trouble, told he needed a knee replacement. I'd seen his wife, and his wife said, "Look, go and see this guy." So he reluctantly came to see me. He said, "Look, I'm wasting your time. My knee's arthritic. I need a knee replacement." I said, "Look, mate, you've stopped using your knee. You're using it like a walking stick. It's weak. It's guarded." He was quite depressed. He wasn't sleeping. So I just graded him through the same process of like giving him a different understanding of his knee, of saying, "Of course it's bloody inflamed. Look at what you're doing with it. Lose some weight, get active, grade up your strength." This guy's back playing hockey. He's just playing in a tournament now.
Wow.
Yeah, that's not saying he's cured, but he's managing the health of his knee. And I think when we start thinking around health instead of thinking around damage, we start looking at a structure and go, "Oh, well, we better be careful with that arthritic knee." Why don't we start thinking around, hey, lots of people have knee arthritis. But what are you doing with your knee? What do you think about your knee? How are you managing that body part? What's your general health like? Because once you change those things, all these other things start to change. And we realize that a lot of these things are massively modifiable because their risk factors are often modifiable. We look at those risk factors. They're the same for knees, hips, shoulders, backs, necks, you name it. It looks the same.
Thank
So
you.
I think we need a massive mindset shift in the way we see the body, as my view, towards looking at health and away from, ill health as our model.
Thank you.
Great. Keith, did you have a question?
Yeah, thanks, Peter. I work in emergency, and one of the questions that I have been exploring is when is it ever too soon to screen for psychosocial stuff?
Never.
Yeah, I agree. And how would you approach? Would you use a tool? Do you just sort of go by your instinct in that setting? How would you manage that?
Yeah. So there's actually there's a paper that I think has just come out looking at screening people in ED, and our group's involved with the study as well, using the Orebro screening tool. So the Orebro, are you familiar with that? That was Stephen Linton's tool. It's a short, that's the one I showed you in my presentation. We screen everyone who walks through our clinic with that tool. So everybody, it doesn't matter if they've got a sprained ankle or a calf strain or a shoulder problem or a neck pain or headaches or back pain, everyone gets it. Now, good care should be screening everybody, and that tool I know has been used in an ED setting before. The good thing about it was actually designed for acute pain. We use it for anybody, but it identifies these factors early, and it's no screening tool is perfect, but it does pick out stuff around people's beliefs, their mood, their levels of anxiety, etc., their levels of pain intensity, those factors are screened, and it is a predictive tool. So I think it's a particularly helpful tool. It also is something that we can then use to ask people, because again, PTs are often not very comfortable to ask people around emotions and beliefs. But if they've filled out the tool, you can easily say, "Hey, look, I noticed that you scored 8 out of 10 around depressed mood. Can you tell me about that answer?" So you kind of you almost give people, you soften them up to the expectation that you're interested in more than just their pain. That pain is an experience that is massively related to, beliefs and emotions. And so it kind of introduces that early, which is, again, why I think these screening tools are particularly useful.
It's pretty interesting to me that I certainly see that population that comes in with 8, 9, 10 out of 10 pain, but with no trauma, no incident or injury.
Yeah.
And invariably, if I'll give them 10 or 20 minutes to just sort of tell me their story and tell me what's going on in their life.
Yeah.
That my informal opinion is that 90% of them will tell me, will identify some major stressor in their life.
Absolutely.
And I suspect that the small percent that don't tell me, just it's still there.
Yeah.
And just spending a little bit of time listening
Yeah.
is powerful, and it's been a real learning experience for me.
Yeah. You know, ED should be called crisis care, because that can be a physical crisis, but it's often an emotional crisis, and it's often a call for help and a sign of someone who's distressed and panics. But we see lots of these people whose lives are in a crisis, and pain emerges often at a time when they're in crisis, and they go to ED. And the problem with ED is that they're often scanned, they're often given opioids, and they're often sent home with opioids. So, you know, you're taking a highly distressed human being and you're frightening them and you're giving them drugs. That is the worst thing. They're not screened for psychosocial factors at all, and certainly in Australia. But, you know, I don't know if you're involved in research, Keith, but, you know, there's a huge opportunity to do some qualitative research with those people to explore those factors, because I reckon that's a really important area to better understand. We presented this data to the ED consultants, and they're like going, "Oh no, we don't do that. Oh no, we don't give them opioids." We go, "We've ordered your notes. This is in your notes. You know, you have done that." "Oh no, it wasn't us." We go, "Well, where was it?" "Oh, it was the junior doctor." So they passed the buck down. But yeah, no, they're doing that. But then we go, "Look, you guys could screen these people," and they're like going, "Oh, we don't have time to do a psychological assessment." It's a 10-point tool. Like, it takes 1 minute. What are you doing? You know, this saves you time. But it's that mindset again. And we have that mindset. If someone's in that much pain, there must be something damaged.
Yeah, I haven't done any qualitative stuff yet, although it's on my agenda. We've just submitted a paper to one of the emergency medicine journals on patients that saw physical therapy had reduced opioids, reduced imaging, shorter
Awesome.
length of stay in emergency.
Awesome.
So
right.
Yeah, we're publishing and looking at more data.
Awesome. Great, fantastic. I mean, to me, that's a really key point, because we often see the translation from an ED setting. It's like their introduction to opioids, and they just get shot down that process. Although a lot of people repeat presenters to ED as well, and we found that 50% of people who presented ED had the same pain before. So it was just a recurrence of an ongoing problem as well.
Yeah, thank you.
Cool.
Great. Anybody else?
If nobody else does, can I ask one more question?
Sure.
One of the challenges I have, I still see patients 1 day a week in the outpatient setting as well, and in emergency as well. That there's really this challenge of addressing the beliefs that have been instilled by the system, and it's such an ongoing challenge to that person that comes in that has been given so many biomedical explanations. And you mentioned that you have to be careful challenging their beliefs, but
Yeah.
You know, that delicate process of beginning to challenge their beliefs and expectations without jumping in too hard.
Yeah. It's a huge issue. And I think one of the things that we often really carefully establish is whether these are their deep held beliefs or it's just stuff they've been told. So some people have just been told stuff, and so they believe it. So like Jamie had been told all kinds of stuff. That's stuff he didn't want to believe. He didn't want them. That was like the worst information he wanted to be given. So he was an open book to change, where you'll get other people who are heavily invested in their health information, where it is part of their identity, it is part of their whole world, and that is so much harder to shift. You know, we've almost created a culture in some people that becomes their pain identity, I think. So much harder. But, you know, it's a bit like that picture I showed you of when you've got a set of stairs and an escalator. Most people will just take the escalator, and sometimes we've got to just block the bloody escalator so they're forced to take the stairs. But our health system doesn't allow for that, because we so readily deliver bad care and we so often don't provide the opportunities for good care. And that's a huge challenge for us, I think, because that is probably where our biggest, challenge is, I reckon, is that you've got huge financial interests who are driving bad care. In our profession as well as in other professions, it's a big problem. So that's kind of like the elephant in the room that, we have to really look at, to go, it comes with a cost to give good care, because actually, we're probably spending way too much money doing bad stuff for people in pain, and we could spend a lot less money doing better stuff. Now that means a lot of people have a lot less money in their pocket, so that's a big problem.
Thank you.
All right, anybody else before I jump in? All right, if nobody else has any questions, one of the big things, I think our profession seems to be kind of in transition, from what traditionally just kind of like, biomedical to this biopsychosocial.
Yeah.
I know you're working with it hard at Curtin with your colleagues there, and, we're doing it at the university I teach at as well. But one of the common struggles that I hear from folks in our group who are in this kind of, in our group, this membership, and just in students in general, when you look at social media and things, is kind of what they're being taught still doesn't jive with what kind of cognitive functional therapy and what social media and the research that you guys are releasing, and other folks like Yonays and Adrian Lowe and all those guys. I'm just curious, what would be your advice to maybe a new physio, but we also have chiropractors and other folks who are pretty up and up with, good evidence-based care as well in our group. Just curious, what advice, like what would you recommend they do to kind of seek out maybe a more comprehensive mode of care that kind of goes in line with the push to this biopsychosocial model?
Look, I really feel for young PTs coming through. Look, in a sense, I've kind of gone through an excruciating process of remaking myself as a clinician, I think, of like coming from a completely structural biomechanical perspective and basically having all my beliefs shaken off my tree. Like, which is like, that's been a pretty painful process, actually, of realizing that fundamentally most of the things that I was taught and believed in are just not evidence-based. So I think the bonus, where it's hard, I think, is where someone comes out of their training and they're still being taught that, because that's old thinking and we can't justify it anymore. But unfortunately, it takes 14 years to change the way the system operates. So that there's this kind of grinding shift to change even what's being taught in universities. And like I get heavily criticized by all manner of my own profession because they see me as some, dangerous, like we're undermining. But I see this as like, I look at my role, trained as a manual therapist, and look, I still use my hands with people all the time, but I'm really careful around how I use them and what the messages I give, and not creating fostering dependency and all that stuff, which I think is just awful. But, I'm not really answering your question. So number one, we have to change how undergraduate or graduate training is delivered. It has to become evidence-based. The problem then is that when those young physios, PTs, go into practice, if they're going into practice which is teaching old thinking, they've got no support, and they'll be criticized as like, this is, this crazy new way of working that's not delivering enough care to the patients, and you need to bring them in regularly, and you got to deliver this, and you got to do needling and learn to crack bones and stuff to care for people. So they're really caught, and I think it's really tough for them, and a lot of them drop out because I think they become completely disillusioned. They go, look, I can't make any money doing this other model of care because there's no one to support me, or I'm working in a practice where I'm actually being told I'm not seeing patients enough because I'm trying to empower them to manage their own care. So because of that, I'm not bringing enough money in, and so I'm now under criticism from our boss because actually I'm not efficient, or I'm not bringing enough money into the business. So there's so many factors that are hard. And, I say to young people, arm yourself with knowledge. Don't spend your money going to workshops that aren't evidence-based. If anyone's promising a cure, don't believe them. It's not true. Find people who you trust and who you respect to mentor you. Get involved in an work environment that is dedicated to high-value care. Although I think that that might be hard for some people to find it. And that is the problem with our transition, is that the other thing, I think we've got a lot of physios who are PTs who are talking biopsychosocial, but fundamentally they're just doing the same old thing. And so it's like, we can talk good and do not good, but to actually work through and adhere to what we know is to be good care is the key. And that's why our real interest is, number one, is to evaluate it, to go, well, is it any better? Because if it's not, then we're just wasting our time. We go back to cracking people's backs and giving them core exercises. So that's why we're doing clinical trials, lots of them. And is it, the other thing that we're really interested in is this whole idea of empowering people with health. And is it saving money for the system? Because if it is, we should be charging that model of care at a much higher level, because we're going to save the system so much money. So, that takes time, unfortunately. And I think, opportunities like this are really important, because I think it can hopefully motivate young people to go, yeah, that kind of taps my values. And I think as most PTs generally go into it because they care for people and they want the best for someone's health. We value, healthy lifestyle usually. So there are things that we want to share with our patients. So it's not a hard shift to go, actually, this kind of makes sense as a good model of care. That's kind of a long way of answering your question, but there are lots of angles to the question, I think.
Absolutely. Thank you very much.
Yeah.
Does anybody else have another question before I jump in? All right. Well, first, thank you so much, Peter. It was really an excellent presentation, and I appreciate you taking the time to be on with us. I'm going to ask you a question that I don't think has a singular answer, and I don't know if you will have the answer, of course, but I would just really like to hear your perspective, because I always get a lot of insight from you. Early on in your presentation, you talked about the disability burden of the percentage of disability burden over the last 25 years, how that's increased in people with low back pain. And I was just kind of wondering what your insight is onto why you think that disability burden has increased so much. Of what factors are playing in to, whether it's societal beliefs, whether it's, just society's metabolic health, whether it's, the increase in the utilization of diagnostic imaging, whether it's the over-medicalization with opioids and surgery. Just wanted to hear your thoughts.
I don't think there's really one, as you said, one answer. And I think if you look into that, there's heaps of things that are probably underpinning it. All of them are the things you've highlighted. Like, we know, for example, we've done work in young people looking at their beliefs. And even at the age of 16, they've got really bad beliefs around back pain. We know that 17-year-olds have 20% of them are taking time out of school and seeking care and taking medication, avoiding activity for back pain. That's 17. That group track into early adulthood. They're predicted to then not just take time out of school, they're predicted to take time off work. So we've created a societal mindset around pain, which is, if you've got back pain, which is really prevalent, that's bad news and you need to protect it and avoid. So that's a recipe for disability. Also got an aging population. We've got a population that's doing less and less. We've got an increase, catastrophe on our hands with obesity and inactivity, and we've got mental health going through the roof. Like, all of those are a catalyst for pain, basically. So we got some massive challenges as a society to deal with this kind of escalated burden. And the way we're caring for these people is we're making them less healthy. So, all of those factors, aging population, lifestyle factors, beliefs, the way we're caring for people, increased access to imaging, the opioid epidemic, the whole lot of it is part of that picture, I reckon. And that's why we see that intervening in this problem has to be at a multi-level. We've got to be targeting politicians. And actually, a sad thing to say, but we were at a conference last year, and we were one of the head medical officers of our biggest health insurer said to change practice, you need a crisis. And actually, the opioid crisis potentially is a game changer for us in one way, to actually utilize that crisis to say it puts a much bigger focus on pain, to say, hey, we've got to do something really different. And actually, it's driving funding towards this problem probably in a larger way than it ever has. So in a horrible kind of way, the crisis may work in a favorable way to bring a shift. And you're starting to see this from the States and various countries around a lot more talk around, utilizing these new models, well, not new, but these models, different models of care for managing pain. And you just, although we know that the more we know exercise is good, the less we do. So we've got these huge, massive obstacles. But it's multifactorial for sure.
Yeah. Well, like I said, I really like to hear your insight, because you always say something that I hadn't thought about before, and it just helps me have a little bit deeper understanding. Does anybody else want to ask anything before I ask another question? I don't want to hog the mic.
Hog away, man.
Okay. So I was hoping that if you could you maybe give us an example or two of maybe some behavioral type experiments that you have used with good clinical success for maybe somebody with long-term knee pain, maybe somebody with long-term neck pain, to start applying these principles away from the lumbar spine?
Yeah, sure. I can give you some examples of someone I saw yesterday. I had a day in my clinic yesterday, and as I always do, I saw an array of people. A lady who has had knee pain for a long period of time, and knee and hip pain. So she's mid-50s, pretty typical presentation, carrying extra body weight. She developed pain around her around a knee and a hip about 2 years ago. She's had multiple interventions, haven't succeeded. She's lost more and more function. She's now depressed. She's lives on her own. She works. She can't care for her grandkids, pick them up. So she talked about her depression, significant life stress. She's frightened of the future. She's losing function, and she doesn't see any way out at the moment. It was very clear. And when I started to examine her, she completely offloaded her right knee, so her right leg. So getting out of a chair, she used the hands on a chair. She loaded her left leg. She didn't load her right knee. So the first thing I've gone is I noticed, what do you notice when you get out of the chair? And she goes, I don't know. I go, well, do it again. What do you notice? And she goes, use my hands. Yep. Why do you do that? Oh, I don't know. Do you use both legs? And she goes, oh, actually, no, I don't. I don't use my right. I didn't know I did. And often you'll see with these behavioral responses, people don't have any idea that they don't do it. They just do it. These are implicit behavioral responses to pain. That protect and avoid is just so ingrained in us, I think, when we have pain. So then it became aware that she was like, I never step up on that leg. When she stands, she doesn't load that leg. When she goes to walk, she's got a leg that she holds rigid. So she walks with a flat foot. She doesn't push off through a foot. So through the course of that session, we just got her doing basic stuff like sitting to standing, using both legs, relaxing her body, breathing, not using her hands, pushing through that leg. She realized actually doing it after a while started, it was tiring, but it hurt less. That engaging with that leg, driving strength through it, actually reduced her pain. that when we started breaking down things like her gait, of getting her to feel the idea of pushing out of her feet and of relaxing her knee and getting drive through her foot, actually normalizing. She said, I have this horrible waddling gait. I don't know how to change it. I'm going, get some arm swing, push through your foot, get confidence in using that leg. So at the end of the session, she walked out, loading the leg, changing her ability to sit to stand, going up a step where she was originally, it was painful, and at the end of the session it was way less painful, with a view of, I can now start engaging with this leg. And I said, what have you learned from this session? She said, I've learned hope. I've learned hope. That's what I've taken from today. You've given me hope. I have felt hopeless. I've had massage and needles and arthroscopies and scans and drugs, and I've felt hopeless. You've given me hope. I said, what gave you hope? You've showed me I can use my leg and it gets tired, and I like that feeling, but it doesn't hurt me, and it makes me feel more confident. So that's an example of someone with hip and knee pain who's got all the classic, arthritis risk factors. And then we talked about, so what are your goals? And she goes, I love to lift my kids. I want to learn to get walking again. I want to be able to travel. And I want to grow older with the confidence that I can keep using my body. So, and she goes, and I'd really like to lose some weight, but I've been so down and so unable to exercise that's become a barrier. So it opened all these conversations. And then I said, look, you mentioned that you've been having a hard time with your mood. What's happening? And then she started talking about all these other factors in her life that were stressors. So kind of at the end of this session, this whole world of this person unfolded. That is often, those conversations don't emerge often when you sit and talk to someone. They often emerge when you start engaging with the body and you realize that people are frightened and avoidant and protective. And I'm fundamentally brave, basically. So I have this amazing belief that the human body loves to load and loves to be active. And so I'll fearlessly take people to do all kinds of crazy things that they don't believe. And I think people smell that in us. You have to believe it to do it. If you're nervous, they'll be nervous. I'll give you another example of a young lady I saw recently who'd had a traumatic injury, like a really serious, life-threatening motor vehicle accident. And this is now 4 years later, where she was really quite disabled. And she was doing lots of things that you would think on paper were healthy for her. She was, trying to exercise and trying to manage, she was saying she was trying to meditate and manage her health and healthy diet. And she was trying to study, although she'd given up on her study because she couldn't manage the pain. So she'd kind of got to the end of really feeling quite desperate as a young person, not being able to spend time studying. And a lot of her pain was related to her neck. And when we started examining it, she was completely guarded with the way she moved her neck. And she was fearful of looking up, of extending her neck. Kind of makes sense. So she had a rear end accident, which was an extension injury originally, and she became completely guarded and avoided of extending her neck. So we then looked at that and gone, well, what do you think would happen if you did extend your neck? Oh, I wouldn't do it. Well, why wouldn't you do it? Do you think it's not normal to look up? Well, I suppose it is, but that's something that terrifies me. Why does it terrify you? What are you thinking? I don't know. I just feel like this terror. And it kind of evolved this whole post-traumatic thing that she had gone through of dealing with her trauma. She just become avoidant of extending her neck. And so she was guarding her neck all the time and, protecting it around turning and moving. And so even though she's engaging in exercise, she's protecting and guarding this neck. So I go, well, let's just have a look at what you do. So every time she looks up, she holds her breath and guards. And we go, how does that feel? It's painful. What do we get you to just breathe and do that movement in a non-threatening way? So I'd put her on her back and cradle her head and just said, look, just breathe and relax as you do that movement. How does that feel? Oh, I don't like it. It's frightening me. I understand it's scary, but do you think it's dangerous? And so often separating fear and danger, I think, are important, Because, yeah, scary. I get it, scary, because you've had a really serious trauma that's frightened the hell out of you. But actually, be like me spraining my wrist. Well, I fractured my wrist really badly a number of years ago, and it was all, put back together with pins. And imagine if I was just clenching that fist all day for the next 4 years. How do you reckon it would feel? Probably feel terrible. That's what you're doing to your neck. So what if we get you to just relax that neck and just gently get some movement? So over the course of that session, we just got her to look up and down at the end, and I got her to put her hands up and look up, and then I got her to extend up, and she's going, you are just messing with my brain. I go, I get that, but how does it feel? She goes, it feels better, but it's terrifying me. I go, I get it, but remember, what you've been doing hasn't worked. Your strategies haven't worked. You can't go back. You can't function clenching your neck like this all day when you're at a desk at work. You know that. You've told me that. I get it's scary, but do you understand that actually that fear is something that may have evolved from that event? But to get brave is the only way you're going to get back living again. So that was the whole conversation we went through around using behavioral experiments to reflect on her experience and her beliefs. And it's probably much more emotionally driven rather than belief driven in her context around a really scary event that threatened her life. And so the body's still in lockdown. So that'd be kind of two examples. The third one was a young guy I saw yesterday with shoulder pain who just stopped using his arm. And I'm going, mate, your arm's designed to move. Like, let's get it moving. So, he would start lifting up, oh, it's painful. Yeah, of course, painful. You haven't used it. Like, get it going. So I'm very, I'm brave with pain. And, this guy was hitching his arm like, oh, mate, get it moving. You want to get these structures. It's healthy for them. It's hurting me. Keep going. And at the end of the session, he goes, my arm feels warm now. It's kind of, it feels different. And like, you've given me confidence. I can use my arm. Now, if I hadn't made him work that arm, now there's always a risk with exposure work. It can go backfire on you. And so I'm always very aware of someone's emotional response and that we don't see an escalating pain response. So I'll monitor that, but particularly the emotional quotient's the key. So how I respond and whether I'm trustworthy and whether I'm caring but confident, I think are the key things. If I'm dismissive of their distress, it can go, you'll quickly lose, they'll never come back and see you, basically. And also telling people, look, you may have some discomfort from engaging with this movement, but no, it's not damaging you. I think that's so important as well. Differentiating pain from damage is the other really critical thing that people need to know. And sometimes you go through a period where you get a bit sore for a start and then you'll get the benefits. So, but focus on living, like this guy can't use his arm, it's buggering his life up. So, focus on the goal because it's worth a bit of pain to get to the goal. And I think we often get engaged in the moment and not thinking around the goal. So there are 3 examples. So hopefully are helpful for you.
Very helpful. That was perfect. I really appreciate you bringing some of your real patient experiences in for us, and I'm sure that's going to be really helpful for a lot of people that are listening along.
Cool. I think one of the privileges I've had is I spend 3 sessions a week in the clinic. So I spend half my life with people who are really stuck with pain. And I think it keeps you very humble because it's not an easy journey for a lot of people. It's a really hard thing to take someone from one position and you don't win them all. We know there are some people who are just, for lots of reasons, are really vulnerable. So it's tough. It's a tough gig and it takes a lot of energy from us as clinicians as well, I think. And that's why we need good support systems because it's pretty draining when you're dealing with a lot of people who are very distressed. But it's also incredibly rewarding, I think. I mean, there's nothing that gives me more joy than to see someone living again, way more than I ever got with, working as a manual therapist, giving short-term pain relief. And I always had a great dissatisfaction with short-term pain relief anyway. I kind of felt like it was undervaluing what I was doing.
Yeah.
You just mentioned a couple of things that you kind of answered a couple of questions that I had, Peter, but I really noticed the confidence in the videos that I've watched online of you working with patients, that sort of bravery that you mentioned, that, you know, not being afraid to move. And it's definitely one of the things that I've learned in emergency, that if people sense that fear, they're really gonna, and so that's but I still sometimes have that fear that you just mentioned of the, you know, when you're doing exposure work and you start to sense the fear in the person, and so the tricky balance of your confidence in their ability to move, that staying attuned to where they're at, and what happens when you're doing exposure work and it blows up on them, because I definitely still have a little confidence issues sometimes if I have somebody that I think might flare.
Yeah. And look, I think in my mind, like I don't ever perceive I'm damaging someone. I think that's the first part. It's really important. Like, you don't damage yourself by moving. The body's not that fragile, you know, like, it's pretty tough. That idea of, so we often talk about watch the face. So, you know, we often watch the body part, but actually the face is where the emotion is. We teach people to watch the face of the person, not the body part, when they're engaging with movement, because the face is where you'll see the emotion. And then question them. So what are you thinking? What are you feeling? What does this make you think? You know, like, get them talking and engaging with you. But you can't do that unless they have your trust. And so the trust bit's the critical bit. And, you know, for some people, we take them very gently. So I saw a young lady yesterday. It's like, you know, classic widespread pain, neck and shoulder pain, comorbid anxiety, depression, you know, not sleeping, diagnosed with fibromyalgia, the whole thing. And she's someone who I just in that session just taught her to relax, because she just couldn't relax. So she wasn't particularly frightened or fearful of movement. She's fearful of this pain that would flare up and just wipe her out. But it was very clear when I examined, she just couldn't relax. So that whole session was really just teaching her to relax her body. It wasn't really engaging in scary movements or anything, because actually that wasn't her issue. So the way we engage the body is really person-centered, and in terms of, you know, where the obstacles are. But I think, you know, if you sense that the patient's not with you, then take the time to build the trust across some sessions before you engage with exposure, because you often only get one chance, I reckon. If you frighten someone, the chances are they won't come back. And so it is such a dance. It's such a fine line. And, you know, I've messed it up heaps of times, but it's also can be amazingly transformative. And I don't know if you've seen JP Canero's papers. I don't know if you've seen them in British behavioral research and therapy, but he followed 4 cases with people with high levels of fear over time, and then intervened with them, and then has explored their pain, their fear, and their beliefs, their self-efficacy over multiple time points. And the journey is really different for different people. We've got other studies coming out that are also doing that, because we're really interested in this process of change. And what JP studies showed was that when someone's confidence or sense of controllability improved and their fear reduced, their disability and pain reduced. So managing their fear and their confidence is the critical elements to engaging with the movement, and then to shift pain and disability. And interestingly, when self-efficacy goes up and fear reduces, pain and disability drops, is what we're seeing in those kinds of processes. So always evaluating that is the key, and always being attuned to the person. And I think fundamentally, letting the patient know you really care for them, I think is critically important, because that's what gets them, that's what will bring them back. If they think you're stigmatizing them, or you don't have time for them, they'll run, particularly if you're engaging with scary stuff. But I think the other thing around that is keep a really clear focus on the goal. That's the other thing I think it really holds people, is like, you've told me you want to do A, B, and C. Let's explore this. So the reason I'm doing this is because you've told me you want to do X. I want to see if we can find a way of giving you some confidence to use your body that let you do the thing you love. And I think always linking your exposure to valued goals is critical, because they can see past the short term towards the long term. That would be my other thought.
That's great. Well, Peter, I want to respect your time. It's coming up on the 2-hour mark, and we really appreciate you spending this time with us. I know I've gained a lot, and the folks that are going to be watching this, not just live with us, but we're going to have it for a bunch of other folks all over the world. So we're hoping to spread this kind of clinical care to more than just our group, and trying to grow this movement. And we just want to thank you for what you're doing for not just physio, but I think for pain in general across the world. I think, I see chiropractic colleagues and a lot of other folks who are, outside of just traditional physio, that are catching on with a lot of your work, and really, changing some maybe traditional ways of getting after it, and helping people that we couldn't help in the past. So I just want to thank you so much for that.
Yeah, it's a pleasure. And look, I thank you guys. I think one of the things that kind of spurs us on, I think, is we see this kind of global community of people who've got one, who care; two, have got an interest in their patients; and three, who kind of see this as a journey. And we need an army of people in this journey. This is a hell of a thing to try and shift. And the more people involved, and the more stories that are shared, and the more we can, as a collective community, engage with that. And the likes of this kind of media really supports that. So, congratulations to the work you guys are doing and supporting that. It's awesome.
Thanks. And it's folks like you that are generous with your time to come on and help us kind of spread the message. So yeah, we agree. We're trying to create the same army of folks, and I think we all work together towards the same cause. So really appreciate it.
Just tell me, what is the obstacles like in the US? Because the few times I've been there, the health looks like it's Australia on steroids.
Yeah.
Awful.
You just have terrible. Just rewarding we have a healthcare system that just rewards expensive, non-value laced care. I mean, fusions and imaging and terrible. All these things are, and then the human interaction in the healthcare system here, it's become so like this, they got to be productive. I mean, some systems are trying to buck that a little bit and move away from it, but we get physicians that are like, even family practice, which traditionally had more time, they're like 10 minutes, and it's like on to the next person. So people are just getting left. Nobody hears any of their story. They just kind of want to put a label on it, and it's easier to just put a thumb on an image than it is to actually, take some time and get to know them. And burning a lot of our healthcare people out. I just hear physicians over and over again who are struggling. So I mean, I don't know what it's going to take to change. The opioid crisis hopefully has given some, like you said, some stimulus for change, but I just think there's a lot of systemic things that are just, in our society, the U.S. just seems to be so capitalism on steroids with healthcare that it's just, I don't know. I'm not saying socialism is the answer. I don't know, but I think we got to step away and start prioritizing and rewarding the right things in healthcare. I think we're rewarding it costs like exponentially more to get a physio session than it would to get a prescription of opioids. Like exponentially. It's the same in
Australia. It's nuts. Yeah. Well, good luck to you guys. We all need it.
I mean, we all have our unique challenges. I definitely think the U.S. is up there, and our statistics, I think, bear it out that we're probably doing one of the worst. Spend the most and get the worst out of it.
We're not far behind you guys, actually.
I did read something that Australia is kind of.
We're horrible. Well, good luck to you all. Good luck to us all.
Thank you so much.
It's a pleasure.
So much. We fight on.
Yeah, good on you. See ya.
All right, take care.
Bye.